GHF would like to thank all of our sponsors. We would like to thank our champion sponsors, Hemophilia of Georgia, and Pharmaceutical Research and Manufacturers of America, in addition to our other generous sponsors that are listed in today's program for their sponsorship and support of this breakfast. Thank you, Laura. I'm turning it over to you.
Great. Thank you, Jennifer. Appreciate the welcome this morning. I'm going to briefly introduce a short video that we are going to share, and then we will kick off our legislative panel. For 9 out of 12 healthcare unscrambled events, if my math is correct, GHF has led with a call to our state leaders to expand Medicaid so that low-income Georgians can have health insurance. There are more incentives than ever on the table for Georgia to expand Medicaid. The American Rescue Plan added an additional $1 billion incentive on top of the generous funding already provided in the Affordable Care Act. One incentive that stands out among the rest, though, is the people that Medicaid expansion will help. This morning, please allow us to share with you one story from the 500,000 Georgians who would benefit from access to affordable health care through Medicaid expansion. Please be introduced to Amy Palauzi. Levi or Matt, do we have our video queued up?
I've lost all of my event business for 2020 as all of those big events happened during the spring and also the fall. And of course, with COVID, all of the events have been canceled because people don't want to gather and haven't been allowed to gather. I have been able to do some singing telegrams because you can stand 6 feet apart and remain, without touching anybody. So I'm glad I've gotten to do something, but my business is down 75%. So I had spoken to some brokers who encouraged me to sign up for healthcare.gov, but they didn't realize, and I didn't realize, that I didn't really qualify for it based on my tax returns. And one of the brokers eventually told me that I would have to either take deductions on my tax return or have health care, but I couldn't do both because I would never qualify according to the system. I don't qualify for Medicaid because I'm not disabled, I'm not pregnant, I don't have children, and that's basically all that Medicaid covers here in Georgia, and it leaves us kind of people out in the cold.
That's why I rise again on the Senate floor to tell the story of another Georgia. A story that gets to the heart of why this bill is important. This is Amy Palauzi. Amy is an owner of a small business, Hairbrained Productions. It is an event planning and entertainment company in Tucker, Georgia. As you can imagine, Amy's company took a significant hit during the pandemic. Unable to book regular gigs and plan events that all of us miss as we have been clawing our way back from this pandemic. Amy qualified for unemployment benefits this past year. And with that critical support, Amy had temporary access to affordable marketplace plans created by the Affordable Care Act. But with the end of Georgia's unemployment benefits looming and the entertainment sector still suffering from the effects of the pandemic, her access to coverage, the coverage she so desperately needs, is on the brink. Again. At the same time, she will have to manage her thyroid disease, high blood pressure, pituitary gland tumor, fibroids, and all the other health hiccups that come along with aging. If Georgia was to expand Medicaid, or if there was a federal Medicaid program for non-expansion states like Georgia, Amy would no longer have to worry about getting reliable health coverage for her chronic conditions. This is the human face of the public policy we make, or the public policy we fail to make.
I would like to say to the policymakers that there's a huge sector of Georgia that's being left out because of their not expanding Medicaid, and it would be amazing if those people could be taken care of.
Medicaid expansion has always been the moral and cost-effective choice for Georgia. The new incentive package just amplifies that choice. Don't tell me you're going to keep this going and send me this lovely letter and then stab me in the back. I try to be as healthy as I possibly can so I'm not needing to run to the doctor, but there's no backup plan when something goes wrong. An owner of a small party and entertainment company, I live to perform, draw laughs and make others feel good. On any given day you might find me delivering a comedic greeting dressed as Marilyn Monroe or Lucille Ball for birthdays or anniversaries, or pranking people's coworkers in a giant gorilla costume or a furry chicken suit with a tutu. You would never guess I do it while living with multiple health issues and no health insurance. While I put on a brave face and focus on bringing joy to others, inside I'm worried because I know I likely can't afford to cover the cost of treatment or even regular checkups or doctor's appointments.
Hi, my name is Amy, and I'm a business owner in Georgia for 26 years, and for most of the 26 years I have not had health coverage.
As our state's healthcare options stand now, Amy says she, quote, doesn't think they care about people like me falling through the cracks. Even more disappointing, when asked what Medicaid expansion would mean for her, Amy was reluctant to even picture that future. She said, well, it's really difficult to say, because I've never had consistent health care. It is hard to imagine. Think about that. It is hard for somebody who works every day. The kind of entrepreneurial thrust, serious work ethic, grit, and determination in the richest country on the planet, she says, it's hard for her to imagine having consistent health care.
Medicaid expansion can't wait.
And acknowledge and thank Amy for sharing that really powerful story, and also acknowledge all of the Georgians that have shared their story with us about what it's like to live day to day with the unknowns of living in the coverage gap and being uninsured. They're so powerful to hear, and we're so thankful for everyone to be brave enough and share those stories with us about why we truly need Medicaid expansion. My name is Whitney Griggs. I am the health policy analyst at Georgians for a Healthy Future, and I have the honor and pleasure this morning of leading our legislative panel. But before I get into the panel, I feel like we may have overlooked something this morning. How about those Georgia Bulldogs? Can we get a go dogs in the chat?
Go Dogs.
Great. Well, I'm very appreciative, especially this morning, to all of our legislators for joining us after what was a very long night / early morning. So I'd like to start off by introducing Senator Dean Burke. Senator Burke represents the 11th Senate District for the state of Georgia, which is in Southwest Georgia, right along the Georgia-Florida border. He serves as the chairman of the Insurance and Labor Committee, the vice chair of the Health and Human Services and Ethics Committee, the secretary of the Appropriations Committee, and is also a member of the Rules Committee. He also serves as the chairman of the Community Health Subcommittee, which is responsible for over 14% of the state's total budget. Senator Burke practiced as an OBGYN for 27 years now and serves as the medical officer at Memorial Hospital and Manor in Bainbridge, Georgia. We also have Senator Sonia Halpern, who represents the 39th Senate District in Atlanta, which runs along the west side of the city. Senator Halpern sits on the Senate Health and Human Services and Education and Youth Committees, among others. Senator Halpern has worked for the Walt Disney Company, ESPN, and Cox Enterprises, and she's also served as a member of various boards and nonprofits. And then last, but certainly not least, we have Representative Lee Hawkins. Representative Hawkins represents the 27th Congressional District, which includes Gainesville. He serves as the chairman of the Budget and Fiscal Affairs Oversight Committee, as well as the secretary of the Regulated Industries Committee. He also is a member of the Banks and Banking, Health and Human Services, Insurance, Rules, and Small Business Development. Representative Hawkins is a practicing dentist in Gainesville, along with, I believe, your son practices with you, and is a past president of the Georgia Dental Association. So again, thank you all so much for being here this morning. Looking forward to a good discussion. And I'll just make one housekeeping note for everyone. We will be doing a Q&A portion at the end of the panel. So if you have questions that you'd like to ask of our legislators, please put them in the chat. And once we make it through the panel, we will open it up for Q&A, and I'll read them to the legislators. So to get us started this morning, let's start off with a big question. Let's kind of start off with what's at the forefront of everybody's mind right now. We know that Georgia's healthcare infrastructure has been hit hard during the COVID-19 pandemic, from rural hospital closures to overwhelming caseloads of COVID patients to public health workers being threatened by Georgians opposed to vaccinations. I think we would all agree that it's not an option to maintain the status quo and effectively provide care to Georgians. So given these huge needs, what do you think are the biggest healthcare priorities that need to be addressed during the legislative session? And what are the greatest hurdles you see in addressing these priorities? And I'll let whoever feels the most moved go first.
Well, maybe I'll kick us off. Good morning. Thank you so much. I'm so glad to be here with my colleagues and with all of you. I think, and we just saw it in the video, right? I mean, the big priority is we've got to figure out how to get our uninsured Georgians insured. Medicaid expansion is one of the legislative priorities that you will see certainly on the Democratic side, and you will hear so much talk about. But I do think that we've got to figure out how to get coverage. The nice thing is that there's broad agreement that we do need to make sure that Georgians are insured. The question is how? What is the solution to making sure that that happens? But when we look at what has happened with COVID and the kind of Band-Aids that's ripped off in terms of the tenuousness of our healthcare system, even for those who already had insurance, we know that there's a lot that needs to be done. Mental health is an area that I know that we're all concerned about, so there should be movement there. And just a reminder that Georgia ranks 48th for uninsured citizens in this country. And the rate, and there's some racial disparities there. We can talk about that later. But even in terms of our overall health system performance, we can do much better than we're already doing, and we should strive to around areas like, making sure that people aren't going without care because of cost, which is a huge barrier, access and affordability, making sure that people have physicians and therapists that they can, and dentists even, that they can have access to for treatment, and then prevention and treatment. So making sure that we get ahead of people's care before it becomes, a much more kind of dangerous situation for them.
Great. Representative Hawkins, do you want to?
Well, I'll say a little something here. Yeah, thank you. Yeah, this is Representative Lee Hawkins. We've been dealing with the same thing, and so the Senate was in the Senate in 2006. And at the base of our problem is availability of health care. And that availability has traditionally, over the years, been very slim. And a lot of that's due to Medicaid rates. We have students coming out now that would be the future physicians and dentists in our rural and South Georgia areas that are not going there because they're coming out with large student debts and with high Medicaid ratios of patients. They cannot begin to pay those debts off, loans on homes. And this was really brought out to us years ago. Representative Butch Parrish, who's chairman of Healthcare Appropriations, we toured the state and went to Macon, Augusta, Savannah, Thomasville. And in Thomasville and Archibald, the head of OBGYN said that she could not attract new OBGYNs because of the low Medicaid rate. In fact, she was losing them. And she presently is pricing it in with herself now. So that's an area that we have to address. We have done some increases in Medicaid rates for providers, small increases. We did target the OBGYNs, but it really hasn't been enough. So when we talk about expanding Medicaid, we first got to make sure we got the workforce for those patients to be seen and treated.
Great. Senator Burke, anything that you'd like to add?
Sure. First of all, good morning, everyone. Thanks for having me. Make sure, can y'all hear my audio okay?
We can hear you.
Okay, thank you. Want to thank my colleagues for being on the call this morning. This was a great evening for Georgia last night. That in and of itself will help the mental health of a lot of people in this state. That national championship jinx off of us. So I appreciate everyone that's had a late night, but also put their working hat on today. As far as my priorities, going back to the original question, I am a healthcare guy. I mean, that's why I feel led to serve, is to try to improve on all those statistics that you guys mentioned about the state of Georgia. One of the first bills that I got passed was codifying the maternal mortality committee and giving them broader powers and some tort protection so they could do the real work of identifying what the root causes are of maternal mortality in Georgia. And they are almost caught up with reviewing the cases over the last, 24 months. And I think we will see some activity this session and certainly next session to use that real data to make some changes. I'm looking at a couple of issues personally this year. One is the working with my House colleagues to extend the postpartum coverage for a full year. Right now, that's already happening because part of the pandemic funding, we actually can't remove anyone from Medicaid since the emergency was declared by HHS. So everybody that's on Medicaid has been on it since they qualified, and until they declare the state of emergency is over, that will continue. So, there's some unknowns there, but certainly my plan is to go ahead and put it in code so that when that state of emergency goes away, that coverage won't go away. There's also I've met with the committee, maternal mortality committee, a couple of times, and one of their concerns is the lack of autopsies on maternal deaths. There are numbers, about 40% of the maternal deaths have not been autopsies, so we really don't know what happened to them. And so one of the things that I'll be working with the House on and the governor's office is trying to figure out a way to increase the level of evaluation of these cases so that we can make better informed decisions. I agree with Representative Hawkins, who's a great friend and serves his district very well, that the Medicaid rates are a significant problem. I remember when I first was elected about 10 years ago, Governor Deal, when I approached him about Medicaid, basically was of the opinion that Medicaid was broken and there's no reason to expand a broken program. And so my feeling is rolling up my sleeves and let's try to fix Medicaid. And we've done a lot of work in the last 10 years as far as rate improvements. We've given an increase to rural hospitals that do deliveries, both on the facility side and the physician side, to try to decrease the numbers of facilities that were stopping OB services. And we have slowed that significantly. In my recollection, there's only been one that's closed in the last 5 or 6 years, whereas 10 years ago, every year there were several programs closing. So I think that has helped. A lot of other initiatives that I don't want to take up all the time going over them, but I do feel very positive that Governor Kemp is investing resources into healthcare, and particularly rural healthcare, in a way that has not happened in my 10 years here at the state capitol.
Thank you all for those answers. I know there is certainly no shortage of healthcare issues that we can address, and the legislative session is just 40 days. So very busy time, but thank you for sharing your priorities with us. I'd like to move on to an issue that I think all of you touched on in some way, shape, or form, which is mental health. We have heard that 2022 is going to be the year of mental health at the legislative session. So far, we've seen the creation of a mental health caucus. We've heard commitment from legislators to tackle the state's pressing mental health needs. And while the increased and invigorated focus on mental health is encouraging, we're also seeing a growing number of Georgians of all ages struggling with mental health and substance use disorders, as well as just difficulty accessing the mental health care and substance use treatment they need. So how will the legislature work to ensure that the growing need for mental health and substance use services is met? And specifically, how do we meet the mental health and substance use needs of our young folks, of young Georgians who have been, seriously impacted by the pandemic, whether it's school closures or, family illness? Would love to hear what you guys are focused on for mental health for the session.
This Representative Hawkins, obviously we're going to be looking at funding, increased funding for mental health in schools. I'm bringing back the ABLE legislation, and we're working on moving that. It's a 529A, moving that back to Georgia. It's been in Ohio with a group of other states due to the administrative cost. This bill will move it back to Georgia and allow more access. That ABLE account includes mental health, includes disabilities because of mental health. So, and then, obviously we'll be looking at providing increased funding to our hospitals in regional areas for mental health. I think also we'll be looking at some of the issues that our law enforcement have with mental health, and allow them flexibility and where they transport those people, and do a much better job of keeping them out of jail and actually in a treatment facility.
Thank you. Senator Halpern or Senator Burke?
Well, to add a little bit more to what Representative Hawkins just said, like 7 out of the 10 youth in our juvenile justice system have some kind of mental health condition. And so I think that the focus on making sure that our young people, not just to talk about our juvenile justice system, but that is an area. I myself, I'm a mom. I have been surprised at, even with my 2 oldest boys, how the pandemic has impacted them. And they've been in schools that for the most part haven't been virtual over this past, year and a half or so. And so definitely a lot of concern about our young folks, especially around issues of depression. And again, some of this is driven by COVID, but a lot of these kinds of issues were trending anyway, and not just in Georgia, but nationally. So the trends were already there, that we were seeing more depression in our young people. Certainly, investments in school counselors, as Representative Hawkins mentioned, is really important so that they can not just identify, but deal with those issues. Same thing with law enforcement and being able to identify issues that they're seeing. One of the other things, of course, outside of just making sure that we're prepared to deal with it around funding, is that we need to make sure that there's mental health parity, so that the way we're treating public health and the way we're treating mental health is the same in the state, that we are in compliance as it relates to copays, and funding for a parity coordinator could be something to help to just make sure that we are in compliance with the law that already exists and is on the books. And that would help make sure that more people potentially have access as well.
Yeah, I agree. This is Senator Burke again. Senator Halpern was dead on from the standpoint of, as was Representative Hawkins, the funding is critical. And I do think that my understanding is the governor is going to recommend a significant amount of dollars that will be directed towards mental health funding. And part of, again, the concern about Medicaid is there was most of the mental health services were not funded on the Medicaid program in the past. And so we have to get that part fixed. I think most every state that has tried to deal with their improvement in their healthcare outcomes in general have found that if they don't deal with behavioral health, that they can't improve their outcomes. And so we have to improve the system of care that we have that puts both of those on an equal emphasis. And the workforce is critical. Again, even if we pay for mental health services, if there's no one on the ground in our rural counties to provide it, then we haven't really done anything. And so hopefully part of this new emphasis on behavioral health will allow us to also work on the workforce issues.
Can I add one other thing? Because when Senator Burke was talking, he got me thinking about one other thing. So we're talking about mental health. I wanted to point out, I am a member of, there's a working group in the Georgia General Assembly on addiction and recovery, and I'm a member of that group as well. And so when we talk about mental health, I also want to just bring into the conversation right now issues around substance abuse, because one of the things that we do not yet fully understand coming out of COVID is what the real impact of that has been to people. And so I think the work that we end up doing this year will be a step, but it may take us time. I think we're going to be lagging behind a really full, comprehensive understanding of just how many people have suffered, even as it relates to turning to alcohol or turning to drugs, because we don't really have a feel on that. What we do know is that, for example, in 2020, we saw an enormous increase in the number of calls to the helplines that exist for people. And so those kind of, and a huge jump, like almost 30% increase in calls to the helpline. And so we know that people are struggling. And those are the people who recognize themselves that they're struggling. We've yet to really contend with the people who haven't really come to an understanding that they have either developed a problem or that the losses that have been sustained over the last 2 years from COVID has even accelerated, issues that they may have already been having. So I just wanted to bring up the substance abuse piece, because I think that's a huge piece of a conversation that is. It's not that we're just starting. We've done things in the legislature all along, for sure. But I think that we are going to be lagging a little bit behind our full understanding of the impact and the full breadth of work that we may need to be doing there too, to help give guardrails and supports to Georgians.
Thank you, Senator Halpern, for bringing up substance use disorders as well. I've read somewhere that substance use, especially among our youth, is the epidemic within the pandemic, and that we'll really start to see the fallout from this even once we've eventually gotten COVID under control. And thank you all for your answers. What I'm hearing from you all is we really need to address mental health as health. We can't chip away at the state's health outcomes without investing in mental health in a robust way. So I know there's many of us joining this morning that are looking forward to seeing how the state works through it this year, and know that we are all there to support and cheering for the legislature to address mental health. So I want to move on to an issue that you guys have brought up a couple of times now, and which you cannot open a newspaper, listen to the radio, talk to your neighbor without hearing, which is the workforce issue. So every industry in Georgia, in the country, everywhere is struggling to keep and attract workers right now. And healthcare is among one of those having the hardest time keeping and hiring staff. We see this across the state in nursing shortages, school health shortages, behavioral health providers, as you mentioned, and even the custodial staff needed to keep facilities operating. So what steps is the legislature going to take this year to address the healthcare workforce shortage? And addressing the healthcare workforce shortage will require a commitment to robust and long-term funding. What opportunities do you see in the budget to address the healthcare workforce needs, not just in response to COVID, but for years down the road, since, as Representative Hawkins, you mentioned, this has been an issue for a long time, and we're now starting to see it all really bubble to the surface.
Yeah. We've been meeting with university and technical schools, looking at ways to increase the numbers of nursing students. That, of course, will require some increased funding. COVID fatigue is a real issue for our hospitals and personnel, not only the nurses, but like you said, even the custodial staff. They've been working, some of them 18 hours a day for the last 6-8 months. So we have lost some of those folks. So we're going to need to focus on building those numbers up. And of course, here again, it's going to take some money. We're going to have to do some of that in appropriations and budget. Luckily, this year, our budget has been strong. Part of that is the federal money that we've received, over $4.17 billion that the state received, not counting what the business community received. So that has helped us, but we have to be very realistic. And when we do the budgeting projects, that this is a continuing cost to the state. So we got to make sure that when we do it, they're strong, and we don't leave it in 2 or 3 years because of the financial landscape. So we're going to be very focused on that this year.
This Senator Burke, I want to add a few things to what Representative Hawkins mentioned. The healthcare worker shortage is national. We have most of the hospitals in Southwest Georgia have lost a significant amount of nursing and respiratory therapists and other frontline workers. to California, New York, that are paying, quadruple or more of the hourly rate that we're able to afford in our rural hospitals. I'm not sure we can pay our way out of that problem. I think what we have to do is provide a work environment that wants our folks locally to stay at home and work. And so most hospitals are working really hard on their workforce development, their support for their workers, whether that's trying to figure out childcare and all these other issues that every parent has to deal with, especially in this pandemic. So I think it's going to take some innovation and creativity for us to figure out what moves the needle and keeps people at home. Now, we do need to increase the volume of nurses that graduate, but if they all move out of state to work, then we've just helped those other states and not done anything for ourselves. So it's a complex issue. The Southwest Georgia AHEC that I've been a board member for a long time has put together a working group over the past 18 months. I mean, this was even before COVID. They started their work on this, and they're coming out with several recommendations. I saw an announcement from the governor's office yesterday that they're providing some of those federal dollars to several nursing schools in the state to increase their pipeline with hiring more nurse educators, which is one of the bottlenecks. We have plenty of people that want to go into nursing school, but the nursing schools themselves don't have enough nurse educators to allow those programs to grow. So it is a complex problem, and it's going to be different how we figure it out in South Georgia than it is in Metro Atlanta. We're not going to have a magic wand at the Capitol that's just going to make this go away. Each region is going to have to figure out what works.
I don't know that I have too much to add to that, because it's a complex problem. And when you think about things, what is contributing to the problem? So again, this is another thing that was already a trend. I think I saw a statistic that as of August of this year, there were something like 11,000 vacant nursing positions across the state of Georgia. So there is plenty of work to be done. And the question is, how can we either entice people to go into the professions or incent them to stay, particularly when, again, COVID has created this extra burden and people are feeling overwhelmed and overworked. So even ideas like state mandated workload limits doesn't really help to get us through the problems that we're seeing. So it is, I would agree that it's a complex problem, and I do think region by region, we've got to figure out the answers. Now, some of the things that we have already done in the legislature, including last session, has been around expanding like telemedicine, right? And some of our interstate compact agreements can help to provide service to folks, even if it's virtually, and even if it's by, somebody who is not sitting right here in the state of Georgia too. So that those being creative around how we're allowing people to access healthcare and good, solid healthcare with again, with guardrails around how that looks. But ultimately, we're going to have to find a way to incentivize people. Maybe it's through scholarships to go into the nursing programs, or go into speech therapy, and go into dentistry, go into all of the areas where we know that historically we have started to see dips. And how can we make those professions worthwhile, right, to the people who are going into them, because they do also have to make a living. And we've talked a couple of times on other questions about Medicare reimbursements and Medicaid reimbursements, but that is a part of this puzzle too. How do you incent people to be able to want to go to different areas of the state and know that they can pay back student debt, and know that they can have a living and survive for themselves and their families?
Thank you for those thoughtful answers. And I think you all make the point that this is incredibly complex and it's not going to be solved in a single legislative session. The legislature has been working to address workforce needs long before COVID. And I really think this is an opportunity. Senator Burke, as you mentioned, it's time to get creative, and it's a great opportunity for advocates and legislators to work together and figure out how do we get more healthcare workforce. So we have time for, I think, one or two more questions, and I'll follow up with another question related to the budget. So the COVID-19 pandemic has laid bare and magnified the racial, social, economic, and geographic inequalities in access to care and disparities in health outcomes. Georgians of color, poor Georgians, and rural Georgians have less equitable access to care and suffer worse health outcomes. What are some legislative and budgetary opportunities that you see during session to address these inequalities?
I guess I'll get it kicked off since I was born and still live in Southwest Georgia, which has many of the worst outcomes in the country, not just in the state. A couple of the counties, especially in my friend Senator Freddie Powell's district, a little north of me, there's just some areas there that healthcare outcomes are atrocious. And again, we have got to develop the flexibility to deal with these issues on what I call a zip code basis. I've had this conversation with our public health folks many times over the last 10 years that healthcare is, if you've got great providers, a great facility, and all of the tools that you need to provide a good service, but you have people, and again, I'm talking about folks on Medicare that have coverage, they don't access the system because of cultural reasons. They're either afraid to go to the doctor or for any number of reasons. And so my point is just putting money into it is not going to help. We've got to get on the ground in the community, find out what the barriers are, and figure out ways to get around that. And the community health worker idea that you guys are playing a part in, I think, is one of the ways to do that. And again, that system, though, if you build it for Metro Atlanta, will not work in South Georgia. It's just different cultures. Culture in North Georgia is completely different. So again, I hate to say these words that it's complex and difficult, but it is. I think if it wasn't, we would have solved it already. And some of the things that I've been working on that I'm most proud of is developing some infrastructure in the state so that we have real data on a granular level. The all payer claims database that we passed, that's being implemented right now out of the governor's health policy team, I think will give us great granular information on a zip code basis of what true problems are, what our healthcare costs are, and where we need to put an emphasis. And the governor's office of health strategy, they have a team looking at these issues, and I think trying to localize what those solutions are. And I think, again, I'm seeing momentum that I haven't seen before on these issues. And so I'm cautiously optimistic that Georgia will start moving the needle on these outcomes, but it is going to be a slog.
Well, I held off from speaking to let my good friend Dean Burke go first. And we're so lucky to have him. Dean Burke is an OBGYN. He is in a hospital administration. He is spent his career in South Georgia, so he has a wealth of knowledge. And he also chairs healthcare appropriations in the Senate. So those are a lot of pluses, and I listen to him. Going back to the 2003, 4, 5 era, I was testifying before committees back then, before I ever ran for the Senate. And one of the things that we worked on was coverage, Medicaid coverage for pregnant women. We got that passed, but like Dean Burke has mentioned, it took time for that really to take hold and people to feel comfortable in that system. And I also agree with him that what works in one community may not work in another. I think that forward-looking, we should consider healthcare connectors, community workers that are helping patients find the care that they need, and often speaking to them in non-medical, non-dental terms, and also these people that are living in the communities, I'm sure have quite a bit of community trust, and that's important. People need to know that the care they're getting is good care, not second world care, and that they will be treated with respect and dignity, no matter what their race is, no matter what religion they are, or matter what their sex is. We're all humans, and I can tell you, when I see patients in my office, I don't see color. I never have. And I don't think healthcare providers do. I think we focus on taking care of patients, and it does vary from patient to patient, depending on their needs.
Well, I think my colleagues really sketched out, when we're talking about equity, there's the kind of more conspicuous racial and cultural differences that we see in healthcare, in treatment in this state. And then there's also the urban versus rural disparity as well. I'll say on the racial and cultural, trust underpins healthcare generally. If I think about some of the outcomes that we see, particularly in communities of color, I can point to the vaccination rollout or the acceptance. You could look at it from either side of the vaccination, but a lot of that came down to trust and who were the providers that were being given the vaccines and allowed to put them in the arms of patients. And without being more inclusive in terms of the breadth of doctors, especially in communities of color, for communities that trust those folks. Here in the Metro Atlanta area, for example, I might not want to go to State Farm Arena, right? And go and get the vaccination from a doctor I don't know, but I will go around the corner to my neighborhood doctor. And so the challenge for us is that we do have to recognize that we do have some implicit bias. We see it in newspaper articles all the time about studies about pain and the assumption that Black women and men have a higher pain threshold and that changes the way that they are treated. And Senator Burke, I know you're all around about maternal mortality, which our rates are bad, but they're even 3 times worse for women, Black women specifically in this state. And so we do need to understand that the racial disparity is pervasive in the state and take specific steps to try to shore that up, whether it's studies, whether it's more attention and effort specifically on figuring out why that exists for communities of color. The rural versus urban disparity, it is unimaginable to what is happening there, quite frankly. Senator Burke, I actually almost expected you to say, because you're in OB yourself, but we have counties, almost half of the counties in this state that don't have a single OB. And so how can you expect the outcomes to be any better than they are if you don't have physicians and access to the preventative care, right? That any patient will need if they're pregnant. I had 3 babies, so I'm speaking as somebody who understands what it means to be pregnant and have to go through it. But, we've got to figure out, and I know some of these issues, they layer on top of each other, frankly, because, if you're talking about there's no OBs in 80 counties, then we're talking about workforce again. And we just touched on that. So many of these issues, while we can look and try to come up with solutions kind of one by one, the reality is they all fold into each other. And if we're and a comprehensive overview of how to take care of this is what's going to really get us further. We do know that those community health centers are very effective. Mobile health centers are very effective if I know that I can continue to see the same physician each time and start to develop a relationship and therefore trust. But the disparity issue is one that we have to contend with, and I think that we know that we are trying to make more investments in rural. I serve a district here in Metro Atlanta, and I would almost argue that I've got communities in my district right here in Metro Atlanta that have some of those same challenges. So I hesitate a little bit to say it truly is rural versus urban. It really, to the point I think that Senator Burke and Representative Hawkins was both making, is you kind of have to look more neighborhood by neighborhood and figure out what are the needs, what are the solutions, and then what can we do to actually fund the solutions that are necessary.
Wonderful. Well, thank you all so much for that insight. And I'm glad we got to wrap up the panel discussion with that equity question, because it's so important, as you mentioned, Senator, very, very layered in all of the other healthcare issues we're trying to tackle. So I do want to take the opportunity to open up a Q&A to the audience. And I've seen some really great questions rolling in. So I'm going to start with one about healthcare infrastructure. As we enter year 3 of the continuing pandemic, it is clear that our lack of public health infrastructure and workforce continues to leave us exposed and underprepared. What proposals can we look forward to for meaningfully increasing our state's public health funding to address this critical structural gap?
Well, I'll jump in and add an idea. I mean, we've talked about Medicaid expansion. I'm gonna throw this out. We have been very hesitant as a state to increase our tobacco tax. So when we're talking about all the needs that we have and where are we going to get the funding, how can we afford to do some of the things that we have all just set out and said need to happen? The tobacco tax and increasing of that is a really strong, ripe opportunity for us that would mean a lot of money for the state. Right now, Georgia is in the bottom 3 states, so we're nowhere near the national average for tobacco tax. And so I am just saying, even if we got to just the national average, it would mean an additional $550 million or so that it would allow us to be able to invest in the areas that we want to invest in. We've got it's just fewer than 8 out of 10 Georgians smoke. So this is not something that is impacting an enormous number of Georgians, but at the same time, we know that every insurance company, if you smoke, that's considered a higher risk and you end up paying more for your insurance for that. If you skydive, that is a higher risk. You pay more for that. And so for those who do smoke, yes, they would be paying more for that, but it would actually put more money into the budget. And right now today, according to the CDC, we are spending as a state, we are spending about $400 million more on uninsured tobacco-related illness than what we are bringing in. We are spending $400 million more. And so even as a business case, right? It just doesn't, it just doesn't make sense. We are choosing cheap tobacco over the ability to create a larger number and ensure a larger number and take care of a larger number of Georgians each and every year by deciding that the cheaper tobacco tax is the priority. I'm going to add one thing since I'm talking about tobacco. The other thing is vaping. So vaping is this other huge issue that has everybody concerned because we do not know the long-term health implications. It's got schools very upset. It's got parents very upset. If we just think about talking about our young people again. And so even that tax and making it slightly more expensive would allow us to discourage more people from doing what we know is not healthy, and at the same time would allow us to be able to fund all of these great ideas that we've just suggested and talked through in this meeting this morning.
I'll quickly just add a couple of things. I know we're running out of time, but I agree with a lot of the comments Senator Halpern makes, and I certainly think that conversation will be out there this year, but it's been out there for several years, so who knows what will happen. The public health, my wife's retired public health nurse, so I heard a lot about the challenges that they had every day when I got home every day for years and years. We in the legislature have to look to the experts in that area to say what's broken in Georgia and what do we need to do to fix it. And I as much as again that I feel like I know what works in my neighborhood as a public health system, I think we need to look for Dr. Toomey and that agency to bring proposals to us as to what they need to be more effective, and then I think we can put our heads together and see how to fund that. So obviously the advocate community, those folks that are working in that space that are not in the agency, need to also help with ideas and recommendations. When people come to my office from an appropriations standpoint, I have to remind them every year that the governor sets a budget, and by the time that budget gets to me, all I can do is move money around. So if I add to public health, then that means I have to take away from education or corrections or some other agency. So I think it's important to realize that because of the Georgia's inability to make or print money, these decisions on how you spend each individual tax dollar is very, very complex. And again, from advocates, always think their idea is the best, but I can promise you those education advocates and those folks that are passionate about improving our correction system and those folks that are passionate about public safety, they all feel the same way. And so it is a challenge. But again, I feel like the trend is in the direction that everybody sees the need that we need to make more appropriate investments in public health. So I do think there is buy-in, but we need to make careful decisions on how we spend those dollars because we can't afford to waste them.
And I will say that I agree with Senator Halpern on the tobacco tax. That was one of the first things I said in the first caucus when I entered into the Senate was let's raise the tax on cigarettes. That did not go over very well because we had just taken a no tax increase pledge, but I didn't mean that for cigarettes. But here's part of the problem. We have a tobacco industry that is cigarettes, cut tobacco, and cigars. And cigars are already federally taxed so high that if we start adding more state tax to those, we can well see closing of some of the cigar shops and things like that. I'm not a cigar smoker, so I don't have a real play in this other than I don't want to see businesses closed. So what I'm saying is there's room for, I believe, an increased tax on cigarettes. We're way behind on that. Like Senator Halpin said, that small increase of 14, 17, 20 cents a pack yields millions and millions of dollars. And it may also preclude some people from continuing to smoke. So I think there's a positive on both ends on that. And then dedicating that money to mental health is where I've always wanted to go with that extra funding.
Thank you for those answers. So I think we have time for one or two more questions. I'm going to lump a couple of workforce questions together. So the first part of the question is, what is being done at the state level to bring physicians and providers to rural Georgia? Things like debt forgiveness, practice development assistance. And then the second part of that question is expanding scope of practice for advanced practitioners like nurse practitioners and physician assistants being further discussed to address workforce shortages in rural parts of the state.
Let me answer the first part, and I'll let the others jump on. Again, I don't want to hog this program, but the state has done a very good job of healthcare workforce development. There is and I won't call them an agency, but a group, the Healthcare Workforce Board, that brings ideas to the legislature on what we can do, and we have done a lot in the last few years. We've got several programs where the folks that are pledged to go back to rural Georgia can get their medical education free of charge with a couple of the schools, and actually have a program where they can get their education and training with a year or two cut off with partnerships with the graduate folks, so that these programs, instead of the normal 8 or 9 years, you can do it in 7 or 8 years. And that may not sound like much, but that's a lot of debt you're relieving on those people. So I do think, from a workforce standpoint, at least on the provider level, in general terms, I'm seeing improvement. We've got a new medical school in Moultrie, Georgia, that will soon be graduating their first class. The PCOM folks are investing millions and millions of dollars in South Georgia, and their part of their admissions process is to make sure they focus on admitting people that have an interest in rural health care. Again, that takes time for that to percolate through the system, but I think it's moving in the right direction.
And I'll just clarify something you said, Senator Burke. PCOM is the osteopathic medicine school. Is that correct?
That's right.
Okay, great. Thank you. Sorry, Representative Hawkins.
Oh, that's okay. No, I agree. Senator Burke, we have it through our Healthcare Appropriations Committee on the House and the Senate side. And again, Dean Burke is the chair on the Senate side. We have worked to increase the loan forgiveness for medical and dental students when going to rural areas. For the medical students, we've also included some of their liability insurance coverage to help them purchase that at a reasonable rate. We have moved money into medical programs so we can have more medical programs throughout the state, especially focusing on Middle and South Georgia. We know that people tend to go back home. They like to go back home. And if we find students in those areas to do the medical school training, and especially if they can train closer to home, we shore that workforce up. And that's very important to rural Georgia, like it's been mentioned by everyone on this program.
Yeah, I will just speak quickly to the second part of the question, which is around expanding services provided by folks like physician assistants and nurse practitioners. And I mean, we have done, certainly last session, which was my first session. So last session, I know for sure that we did some work towards allowing folks to be able to write some prescriptions, for example, with a doctor's oversight. I am hopeful that we will be open to allowing and really thinking strategically about how to use the folks that already have training and allow them to be able to do more within the right scope. And again, going back to what Senator Burke said, making sure that we understand the parameters and what the needs are, and that we're not just overstepping a physician's bounds, but certainly thinking about the folks that we already have in place and how do we allow them to maybe do more that they have been trained to do that we just typically have not allowed them to do, especially knowing that we have the workforce shortages that we have and the patient needs that we have at the same time, and balance those things out. So I'm hopeful that we will be open to more discussions around expanding the services that we allow folks who are already trained to provide.
So I'm going to wrap us up with one final question from the audience. How can citizen advocates have the greatest impact on these issues? Senator Burke, you mentioned as being on the Appropriations Committee, you hear from everyone about why their issue is the most important issue and needs all of the funding. So what can just regular folks do to lift these issues up with their representatives?
I think the first thing is just getting to know their personal representatives and not meet them when they're asking for something. Most of the folks that serve are working every day in their community, and I'm always excited when somebody reaches out and wants to discuss a problem that actually lives where I live, because most of the time the people I interact with are advocates that's their job, and they're frequently located in the metro area because that's where the capital is. And so I think the biggest thing is to develop trust with your representative or senator, and if you treat them professionally, they will respond, and you can be their go-to expert if it's a subject matter that they're not fully knowledgeable about. That's what I do. I mean, when I have an education problem or question that we have to deal with on the Senate floor, I call the educators in my district and ask them, what do you think about this? What's the right answer? Because I'm not a full-time educator. And obviously the same thing goes for banking or insurance or whatever. We are all citizen legislators, and I feel like I'm very knowledgeable about healthcare, but even there, as I already mentioned, there's certain aspects of healthcare delivery that I'm not an expert, and I certainly want to yield to those that are. And I think that's the best way is just develop a relationship and trust with your personal legislator.
To follow up on that, we're talking about health this morning, and so when I think about that, I also think about when is the time to speak to a legislator? Well, obviously, all during the year, waiting to January and February, the budget's already been pretty much settled on. Like Senator Burke said, we're given a budget and appropriations, and I said on appropriations and the subcommittee health appropriations, we don't have a lot of money to work with in health appropriations, not as much as I would like to have, but we do focus on things. We focused quite a bit on sickle cell anemia over the years, and some of our schools like Morehouse that's doing a terrific job training medical students. I may add, Valerie's a real prize to have her as a dean down there. But to answer that question. I think it's important for constituents to speak to us, like I said, all during the year, get to know us, not when they're just asking for things, but just to get to know us, one-on-one. It's always easier to ask a friend to borrow a football than a stranger to want to take your football, and then you're having to think about that. So I would say engage early, engage often. Do it in a way that's in a friendly manner. I think one of the turnoffs that we get is people demanding and almost with a threat. A lot of the emails that are like that. Luckily, majority of our emails are very positive emails, but we do get the negatives from time to time. But all in all, I think access is important, and us hearing from our folks in our community. So that's what I would advise.
I will only add that healthcare should not be a political issue. And so depoliticizing healthcare and being able to talk about what needs to be done should also be a goal. And I think part of the way that we get there and part of the approach to legislators is to share your stories. Because what we do know is cancer doesn't care who you vote for. Diabetes doesn't care who you'd like to see elected. And so the more people can also share their stories, it's also a very good reminder to us that at the end of the day, we are talking about people, we're talking about their lives, we're talking about how to improve their lives, and sharing the stories really does help to underscore the work that then we should set out to do, and how we then can come to agreement as to how to move forward step by step on making sure that we're able to resolve and solve for some of those issues that we know that Georgians and constituents actually are experiencing.
Great. Well, thank you all so much for joining us this morning. I'm sorry that we weren't able to get to all of the questions in the chat, but as you heard from our legislators, reach out early and often, and feel free to ask these questions directly of them. And thank you for joining us after such an exciting late night last night. Go Dogs. And I'm going to turn us over now to Laura Colbert, Executive Director.
Hi, great. Thank you to everyone. Thank you so much to our legislative panelists. I know all 140 or 50 of our guests this morning really appreciated hearing from Senators Burke, Senator Halpern, and Representative Hawkins. Thank you all for being here, again, really early after a late night of football and sharing your expertise with us. Whitney, thank you so much for hosting such a great panel. I'm Laura Colbert. I'm the Executive Director here at Georgians for a Healthy Future. And one of the privileges of being in my position is that I get about 10 minutes every year at Healthcare Unscrambled to talk about almost whatever I would like, not whatever I would like, but almost whatever I would like. And this year, I'd like to use my time to tell you a little bit about a friend of mine, Michael Daniel. And you'll see Mike D, as we call him, here on the screen. I met Mike when he came to work for my husband's bicycle shop back in 2012 or 2013, as best we can remember. My husband has been open for business for 11 years, and he's only employed about 6 people during that time. So people stay for a really long time, and then we end up building very close relationships to all of them. And Mike was no exception to that. He was chosen family, and he even walked my mom down the aisle at our wedding. And you can see him here also with a friend of ours, Jared. Mike was really easy to like. He had a great smile. He had a very charming laugh. And as my friend Kaylin puts it, he talks to you like he was telling you a secret, like he was making you part of the inside joke. And I always felt like I was part of the cool kids club when I got to hang out with Mike. Mike dabbled in a lot of things. As I mentioned, he worked on bikes, he was a butcher for a time, he bartended, but several years ago, he started training under his grandfather, Travis, in Thomaston, Georgia, to make handmade knives. And Travis makes knives of all kinds, pocket knives, hunting knives, kitchen knives. And Mike loved his grandfather more than anything in the world. And he really seen that relationship, that love seemed to really make Mike want to make knife making his profession as well, and to make a small business of his own out of it. In addition to what I've already mentioned about Mike, Mike also partied a lot. We all did for a while in our little bike shop crew. My husband and I even bailed Mike out of jail once or twice after some bar fight or fallout from some late night or some trouble that he'd been in. And at some point, Mike's substance use escalated, and it went from late nights at bars to using things like Oxycontin and then eventually heroin. And because of Mike's addiction and some of the behaviors that came with it, at some point, my husband and I chose not to have Mike in our lives anymore. And that was a really hard decision that came with a lot of complicated feelings. But we're part of a small community, and as it is with small communities, we would hear updates about Mike every once in a while. We heard he moved to Charleston, and then he had moved to Asheville, and then in the spring of last year, we heard he had moved home to Thomaston, back home with his family. And in the summer, we heard good news. We heard he was trying to find his recovery, trying to figure out what sobriety meant to him. And then an update after that in the fall. On November 1st, my husband got a text from a friend that Mike had died from an overdose the night before. Excuse me. I practiced this a couple of times and I never got through it without tearing up a little bit. The following weekend, we went to Thomaston for Mike's memorial service. And we hugged his mother, and we shook his granddad's hand, and we shared stories about Mike among friends. And it was a very small consolation while we sorted through a tangle of very complicated feelings. And I'm telling you about Mike because while he was special and unique to us, his story isn't all that unique, unfortunately. Mike is one of what will likely be 2,000 deaths from drug overdose in Georgia this year. And Mike was complicated, as was his addiction. And that's often how mental health and substance use issues are. They're incredibly complex and they differ from person to person. And even in the face of all that variability, those of us who work in public policy, we kind of lump it all into one big umbrella issue, behavioral health. And because it's so big and complex and varied, it lends itself to very complex and difficult policy solutions. And as our legislative panelists alluded to this morning, in Georgia, we've made a really good start, but we have a long way to go. Even before COVID-19, mental health and substance use issues were at crisis levels, and the pandemic served to accelerate that. Between May of 2020 and April of last year, drug overdose deaths statewide increased by 33%. Fentanyl-related deaths have more than doubled. 1 in 3 Georgia adults reports symptoms of anxiety or depression, which is actually down from the high of 4 out of 10 of us. And pre-pandemic, those levels were more like 1 in 10. So you can see anxiety and depression has increased 3 or 4-fold. Kids and youth are not doing any better. The prevalence of depression and anxiety during COVID has doubled among young people, and the proportion of mental health related emergency department visits among adolescents has increased 31% in 2020 compared to 2019. It will take a lot of time and dedication to put in place the many, many policy pieces required to slow or stop our mental health and substance use epidemic. I hope that as a state and a nation, we can walk and chew gum at the same time, as the saying goes. We certainly can't abide the death and disability that COVID-19 is causing, but we also can't ignore the other incredibly urgent health issues that face us while we deal with COVID-19. And that goes beyond mental health and substance use. There are many urgent health issues facing us. We have to be able to do both. And I hope that we can take on the mental health and substance use crisis with the same characteristics that, in my observation, it takes to find mental health and substance use recovery. Those characteristics include, among many others, urgency, courage, compassion, creativity, and long-term dedication. And when I thought about the many health issues that I know our audience members are working on and that we are working on alongside many of you, many of those health issues would benefit from the same kind of approach, this urgency, the courage, the compassion, the dedication. And many of them would benefit from the same shared solutions that would help to address mental health and substance use. Public policy issues like universal health coverage, community-based integrated healthcare that's culturally humble, healthy housing for all, shared economic opportunities. The list goes on and on. I could be here all day. GHF is committed to being a part of achieving those policy aims, policies that move Georgia out of our last or almost last place in many of our health rankings. And I think that if you're here with us this morning, you are dedicated to seeing those policy aims achieved as well. So thank you all for being here this morning and for being part of this collective work, and for letting me share a few small things about Mike. Before we dismiss for a short 10-minute coffee and movement break, I wanted to say thank you to a few people. First, thank you to my friend Kaylin Gilstrap. She is a friend and also a photographer. You may have seen her at some of GHF's events. She let me use 2 of her beautiful photos of Mike this morning, and she's also posted her photos and her own reflections of Mike on Instagram today in coordination with this event. And so we'll put a link to that in the chat so you can read about it and see a few more images. We've also put in the chat information about the CARES Warm Line. If you or somebody you love is struggling with addiction or substance use, I hope you'll reach out. The Georgia Council on Substance Abuse operates that warm line and is available to connect with people as needed. I also want to say thank you to the GHF staff. We are a bigger team these days. Lois, Kanetta, Whitney, Alex, Daniel, Deanna, Traylyn, and Andy are the amazing people behind GHF's work. And I hope that for those of you who have not yet met all of them, I hope you get to meet each and every one. I hope you get to work with them and learn from them as I have in the coming months. Thank you to our board of directors. We are currently going through strategic planning, and as those of you who've been through that process know, it takes a lot of important and honest and tough discussions. GHF's board members have proven themselves up to the task, and we really appreciate their committed leadership of this organization. So thank you. And thank you again to our sponsors and donors this morning. You all make this program possible, and you also help support our year-round advocacy. So thank you, thank you, thank you. At this time, we're going to take a 10-minute break. So please refresh your coffee, get up and move around, do what you need to do to take care of yourselves. And whatever you do, be back here right at 9:40. So I guess an 8-minute break, really. Be back here at 9:40 to hear from Dr. Benjamin, Executive Director of the American Public Health Association. We are so looking forward to his words of wisdom. Don't miss it, and we will see you in 10 minutes.
Good morning, everyone. I hope everyone has enjoyed the first session of our Healthcare Unscrambled this morning. Again, we want to thank our legislative partners for joining us this morning. My name is Chastity Walker, Dr. Chastity Walker. I'm an epidemiologist at the U.S. Centers for Disease Control and Prevention here in Atlanta and board member of GHF. It gives me great pleasure to introduce you to our Keynote speaker, Dr. Georges Benjamin, Executive Director of the American Public Health Association, the nation's oldest and largest organization of public health professionals. Dr. Benjamin's commitment to public health is demonstrated by his tireless service in this role since 2002. And it looks like he is prepared to go much longer. Under his leadership, APHA, in coordination with its members and affiliates, works with key decision makers to shape public policy to address today's ongoing public health concerns. Those include ensuring access to care, protecting funding for core public health programs, services, and infrastructure, and eliminating health disparities, among other critical public health issues. Likewise, GHF's priorities are to expand coverage and increase access to healthcare for all Georgians, while taking a population health approach as we seek opportunities to address social determinants of health, the conditions in the places where people live, learn, work, play, and worship that affect a wide range of health risks and outcomes, and inequities that negatively impact individuals, families, and communities. The COVID-19 pandemic has presented unprecedented challenges and exacerbated long-standing systemic health inequities that put people experiencing disadvantage at an increased risk for COVID-19 illness and death, and has once again exposed how racism and where one lives determine to a large degree a person's life trajectory in this country. It has also shined a critical light on the need to radically transform our public health systems if we truly want to create an equitable society. Ensuring health equity is not only essential to ending the COVID-19 pandemic, but critical to saving lives. APHA continues to be an outspoken advocate, sharing science-based information with the public and support for outbreak response funding during the COVID pandemic, so that individuals, business owners, and communities can make the most informed decisions possible. All of us gathered here today are beneficiaries of public health in one way or another. Georgians for a Healthy Future, together with our legislative and public health partners, have a role in working to reduce and ultimately eliminate health disparities and inequities by addressing the structural and social conditions that give rise to them. And in order to build a resilient public health infrastructure, we must all commit to doing what we know works and push beyond the status quo to ensure we drive innovative action and continue to lead in advancing health equity. We look to the leadership of Dr. Benjamin and others to guide our efforts. So without further ado, please join me in welcoming Dr. Benjamin. I'll turn it over to you.
Dr. Walker, thank you very much for having me here this morning. And let me just say that, go Dogs. I was excited about that win as well. And, this is, just so you see, APHA is actually celebrating its 150th year. We were founded in 1872. So we've been around for a while. And this year we'll be spending a lot of time every month with a different theme, talking about how to improve our health and part of our celebration, both looking backwards as well as looking forward. So with that, I'm gonna share my screen here, and let's talk about where we need to go. I'm gonna do this through the lens, of course, as you can imagine, of the COVID-19 pandemic. Recognizing that the practice environment for public health has dramatically changed, very much so. And, we've got a obviously renewed focus on infectious diseases because of COVID-19. Chronic diseases and injuries still predominate the things that injure people. The social determinants became much more visible as an underlying health factor. We now know that clearly our health risks are globalized. If we didn't believe it before, COVID-19 has solidified that in the minds of the population. And aging in a more diverse population is certainly in our environment as we have it today. We know that social media and the internet now drives a range of health behaviors. The fact that this is a 24-hour day, 7-day-a-week experience, the fact that it is so predominant in people's lives means something we really need to deal with more assertively as a public health community. We've got lots of disruptive technologies. You know, just as we thought we had our hands around tobacco, we got e-cigarettes. And so continuing our society is changing with new tools that we as a public health community are going to have to address. Driverless cars, texting while driving, all those kinds of things are things we now have to address that we didn't have to 20, 25 years ago. We used to brag about the fact that public health did its best work when nothing happened, and that we were invisible to folks. We're quite visible now, for better or for worse. And to some degree, that has been part of the reason that public health has now become overtly political. We're on the minds of everyone. The fact that legislatures are having so many discussions around public health and this conflict between individual rights and collective rights is something that we as a society are going to have to figure out how we address. Public health has always been a federal, state, local partnership with our governmental public health entities and our many non-governmental associations and organizations that are involved in improving our health. So it is really we talk about the three-legged stool, but it really is a four-legged stool when you include the non-governmental associations. And then when you add the private sector as part of that, as many of you have seen maps which bring in all aspects of public health as part of our society. One of the challenges we have is that our public health system has developed over time. It's not something where someone set up with a white sheet of paper and said, boy, I want to design a system to protect the public. And unfortunately, that system was not designed or resourced to meet the strategic needs of the nation. It has not ever been. We're only about 3% of the healthcare dollars. And as you can see right now, we're having lots of debates about what public health is and what it isn't. It's really in many ways a patchwork of programs and funding streams to address health promotion, disease prevention, and health protection. And the emergency preparedness capacities that have kind of always been there have exploded over time, particularly since 9/11. The challenge, though, is that, like many things, the federal funding has not kept pace for this, nor the local funding, I might add. But we know that federal funding back in 2003 began to be reduced. So now it's 50% of the funding for hospitals and 33% of the funding for basically governmental public health has been reduced. We know that public health, the governmental public health entity, is the only entity that has the legal responsibility for the health of the community. And that makes that very special. That means that the governmental public health entity has to be the chief health strategist for that community. We know that public health is governed locally and managed as a partnership, like I said, between federal, state, and local. And some of the key organizations, ASCO, NACHO, the state health officers, the local health officers, all of their affiliates, the groups like the CDC Foundation are all part of this collection that we have, which provides enormous support for our state and local health departments as they try to govern public health. Tragically, we're now seeing our public health legal authorities threatened. We all thought that a lot of this was settled when Jacobson versus Massachusetts was passed in 1905, which clearly said that public health folks, this was a vaccination mandate, and but it also really dealt with this issue of collective responsibility for our health. That was a fundamental part of that Supreme Court ruling. And we're going to see whether or not the court continues to feel that collective health is important. So far, in many of the vaccine efforts, the court has stood behind public health, but not all courts. And we're going, as you know, we have a big case in front of the Supreme Court right now looking at vaccine mandates, both from the OSHA perspective, from the CMS perspective, and vaccine regulations from the OSHA perspective that are in front of the Supreme Court today that we're hoping the court will rule, as I believe, properly and support both the OSHA and the Center for Medicare and Medicaid Services in their ability to help promote the vaccine, mass and social distancing in the in our workplaces, so that our workplaces are safe. Now, we know that public health still operates in an incongruent fiscal environment, and it's frustrating, I know. Something very, very bad happens. And then some money gets put behind it. Often a little bit too late, sometimes not enough. But the real challenge is that the expectations of performance far exceed the money. Congress has a tendency to put money on the table and then to take the money away. In fact, we've seen this at the local level as well. And that does not build any long-term capacity. The fact that you take a lot of money and throw it at a system at a time when it's very difficult to spend it in a responsible way, in a thoughtful way, and then it goes away so quickly before you really build capacity, is a real problem that we're going to have to continue to figure out how to address. And I know that all of our legislatures are in session right now, so this is something we ought to press them on. You know, how to make sure that we maintain those fiscal capacities over time. We know that this is an example of what that funding has done. You know, we kind of peaked in the early 70s, and then now we're at our nadir in terms of public health funding. And then when you think about inflation in terms of real dollars, it's been even a worse situation than you see right here. We also know we have phenomenal workforce decline. Part of that's been due to the recessions that we have, where dollars have been cut, money has not been available, people have left, and those positions in many cases have not been reestablished or not funded. A lot of it's going out to consultants, which doesn't actually build any capacity either into particularly your governmental public health entities. The basic work for public health has not changed. This is the new 10 essential services map. Bottom line is every public health department has to know when a new health threat enters the community. They need to have a mechanism to craft and implement solutions to that threat, and then ensure that it gets done. And the 10 essential services, which have now been crafted around equity as the centerpiece of everything we do. You remember research was in the center of that previous 10 essential services chart. Equity now is in the center. It always really has been, but now this is much more explicit. But the idea of recognizing that we want to make sure that everybody has an equitable opportunity for good health ought to be at the centerpiece of everything we do. And our ability to do research and evaluation ought to be part of an ongoing process that is not simply one point in time in our efforts to improve the health and well-being of our populations. So let's talk about what we learned from the pandemic. Obviously, we had this big outbreak that hit us towards the end of 2019, going into 2020, and we're continuing to deal with this pandemic. We know this is the worst pandemic. We've had it over 100 years. These are the numbers as of January the 6th. I can tell you that these numbers obviously have continued to grow. And while I know that we're tracking cases, as you can imagine, a lot of our enumeration of the cases is not accurate right now, particularly with the advent of home tests, self-tests. We're tragically underreporting the number of cases, particularly Omicron, which is a disease which is highly infectious. So as many of us are talking about how we go, we're going to be pivoting more and more to looking at hospitalizations and deaths. You always have to have some surveillance on, evaluation and numbers. So numbers are important, but just understand the more accurate way to look at this pandemic as we go forward is going to be around hospitalizations and deaths, with some understanding of what the prevention efforts are in terms of vaccinations. We know that we had some overall systems failure. So frankly, we've had failure of leadership and accountability at a variety of levels. The original pandemic preparedness was not based on universal pandemic model, was based on kind of a flu model. Turns out the flu model is very different than this particular outbreak that we've had. Quite frankly, though, if you go back and look, much was predictable based on history, prior emergency experience, and evaluations. And as a nation, we just simply did not fix what we knew was broken. We did not put in place the kinds of things that were needed to address this pandemic. This was frankly not a failure of science or technological discovery. We've had amazing scientific and technological discovery. We're doing things 100 years later from the great pandemic that we were never able to do. And I've had the opportunity to go back and actually look at the record 100 years ago, because the American Journal of Public Health published a lot of this stuff back then. And we actually had an association which had an annual meeting during the great pandemic. And I've looked at the minutes of those meetings. And so this is not really a failure of scientific discovery. We've learned a lot over the last 100 years, but it has been a major failure of resources, capacity building, how we deploy the science and technology, and the processes for readiness, preparedness, and response, much of which we know how to do that we haven't really employed. It's been undermined to some degree by many of the political activity that's happened as well. And we've had single points of failure. Testing is a single point of failure. Our supply lines are a single point of failure. These are not things that we have not known. I was a health officer in Maryland doing the anthrax letter, and we recognized at that time we had single points of failure. Things like personal protective equipment, et cetera, were going to be a problem. Our ability to scale up rapidly for testing and those kinds of things was going to be a problem. So these are not problems that we hadn't identified. We simply didn't fix them. So I'm going to look at this thing through the lens of these 5 things: disease surveillance and laboratory capacity, data information capacity, science and risk communication, health inequities, and vaccinations. Are kind of the best way, I think, to kind of look at what's happening as we begin looking for the future. So we know that we have these siloed disease reporting systems, which we have to fix. They were designed, because somebody had an interest in heart disease or cancer or pick an infectious disease, and they don't talk to one another. The lack of a single patient identifier is a big issue here, because we also have to spend time deduping data that gets put in the system. Our ability to do genome sequencing and advanced molecular detection, something that Tom Frieden, when he was CDC director, championed, and the Congress did begin to fund. But we're well behind the rest of the world in our ability to rapidly identify variants. So, there are lots of variants that are around, but we just aren't collecting them and identifying them and cataloging them in a meaningful way. And our modeling capacity, even though we have great places like Yale and University of Washington, Seattle, the Institute of Health Metrics there, which is doing phenomenal modeling. As a nation, we had to interact with those private sector entities because we really didn't have the inherent modeling capacity to look at things. The military does this all the time, and public health has got to figure out how we put in place more modeling capacity, which is robust and can predict a series of potential futures that we can then respond to, very much like the meteorologists do for the National Weather Service. We know that a lot of our pre-analytic capacity, as I said, we knew that some of these things were wrong. The federal stockpile was inadequate. We knew that at the end of the Bush administration. Quite frankly, Congress did not give us enough money. The asks were there, both during the Bush administration and the Obama administration, but it's been problematic for a while. We have to fix that. We know that our analytic capacity, we had an enormous ability, particularly in the private sector, to do things, but again, had not scaled those up as we needed to. Data sharing, the fact that we still have state and local health departments that are sending information by fax machine. Fax machines are interesting. They may have some value for some points of communication. But for those of you who are old enough to remember carbon paper, I would argue that fax machines need to go the way of carbon paper with the new technologies that we have. Our paper-based systems are inadequate. The interoperabilities I mentioned are inadequate. And this is something we've got to fix. We have this challenge with risk and science communication. I like this cartoon. This is actually a 1930 cartoon. Many of you may have seen this even on social media or in the media. This actually comes out of a cartoon book that the American Public Health Association actually published. It's a little small book. I actually had it on my desk the other day. But it talks about misinformation back during the smallpox times. And you can see these are 4 blind men wearing sunglasses or purposely shielding their eyes from the truth. And of course, now the anti-vax movement is on steroids. We also had anti-mask issues back during the Great Pandemic. But back then, we mandated masks in many parts of the country, and our political leadership got behind the public health community. They did not thwart the public health community as we're seeing that today. You know, communicating involves knowledge, and that knowledge evolves over time. You know, actually masks work. And, you know, this is an interesting chart. This chart's been done in almost every community that's had a chance to look at it. This is Kansas, where the governor allowed masks to occur, but did not mandate masks at the state level. And you can see here that these areas that had masks had high degree of disease, and these communities that started putting masks on had reductions in the outbreak. Masks work. This disease primarily functions as a droplet spread disease. Yes, it has an aerosolization component to it, which makes a big difference here, but that's not the predominant way you get it. And like anything, the tighter the mask, the better the mask. We've always said that. That has not been a change in guidance. I know CDC is talking about whether or not they're going to more actively promote N95 masks. People should not see that as a change in guidance. They should see that as a emphasis change, but not a change in guidance. And we've got to do a better job of actively communicating. Because we still having our communication challenges. And I'm a strong supporter of our CDC director, but it has been a steep learning curve for them. And I'm glad to see that they're now doing their own press conferences so they can sit out there, explain the science, instead of these short press releases and snippets that the media is getting. They're not necessarily getting the message right. We know that social determinants drove the COVID-19 and inadequacies we saw, primarily because of exposure. People who had to go to work were much likely to be exposed to the disease. And those tended to be people of color and people in public-facing jobs. They couldn't shelter in place, as I could during the last couple of years. Susceptibility, the fact that the prevalence of chronic disease in those communities, that meant that if they got infected, and you had diabetes or heart disease or lung disease, you're much more likely to have a worse health outcome. This was not a surprise. We've seen this with every infectious disease outbreak. So it should not have been a surprise to us. And in fact, in China, in the early part of their epidemic, we saw this, this problem with disparities with people with chronic diseases in other countries. We just didn't, again, act as fast as we needed to offer testing, offer counseling, and now have offered vaccinations into those communities that were most at risk. And the lack of paid sick leave and poverty and housing situations. Obviously, if you live in a big house, you're much more likely and easier to separate yourself from others. And that's one of the reasons we saw such a high prevalence of inter-household spread when someone got a disease, because they were out and about in their public-facing job. And that's why we saw these huge disparities. And there's no question that structural racism, fundamentally, we have to make sure people understand what this is. This isn't about, I don't like you, but it's about the fact that systems have been put in place for years based on race, based on economics, based on where we put plants, where we put businesses, some of our policies. No, I don't think physicians get up every morning thinking about how they can discriminate against patients, but they need to make sure that the policies and practices in their practice allow for patients to be treated equally. And we do know that the practices and policies in many places do not treat people equally. And we need to identify those and correct them. And we know that the outcomes show that, particularly with Native Americans, were heavily hit by this. That doesn't get talked about enough. but African Americans and Hispanics, and then Asians in some communities, particularly in California, for example, particularly in Southern California, where there are huge disparities for the Asian community as well. So there are disparities based on location. I mean, rural communities in some places got hit heavier than in some places in other rural communities. And we know it has an ultimate impact on life expectancy. These are provisional data. By the way, this data has now been confirmed. But as a nation, we lost a whole year of life expectancy during this pandemic. And for some populations, such as non-Hispanic Black males, 3 years loss of life expectancy. You know, a half year gain or reduction in infant mortality, we celebrate, we jump up and down. We're excited about it when we improve life expectancy by half a year. But getting this back is not going to be easy. It's going to be a really, really tough problem. And by the way, prior to COVID, we were losing life expectancy because of substance abuse and obesity. So we've got to do a lot more to address these things. And by the way, those epidemics did not go away during COVID. We still have an epidemic of obesity, which had gotten a little better, but now has gotten worse. We have an epidemic of opioids. 100,000 people died prematurely from substance misuse. That epidemic hasn't gone away. The STD epidemic, which was beginning to raise up right before this, did not go away. In fact, it's gotten worse. Firearm epidemic did not go away. So while we're worried about COVID, we need to recognize that we have broader public health and societal issues we're going to have to address as well. I give the Trump administration enormous credit for Operation Warp Speed. This was a sound strategic decision, and in most cases did not get politicized. And I'm glad to see that everybody is promoting vaccines, including President Trump, because I think vaccines are the way out of this for us. While we may not get sterilizing immunity, meaning that it doesn't protect 100% from getting infected from the disease, it is highly, highly beneficial from keeping you from getting really sick and dying. And I think when people think, well, should I get vaccinated because I can get infected anyway? Yes, you should get vaccinated because you won't get really sick and you may not die. That's the reason you should get vaccinated. And if there's not a reason for not getting vaccinated I can think of is that I don't want to get really sick and die. Sniffles, not a big deal. Really sick and dying, big deal. What we didn't do was we didn't plan at the same time for the distribution of vaccines. And so that has been, was an issue. Although the good news is the Biden administration has taken the bull by the horn on that, has really ramped that up aggressively. This is a gentleman that I'm actually me vaccinating him. This was his the week of his 100th year birthday. He was an advocate who wanted everyone to know that Mr. Harvey Ziegler, who wanted to get vaccinated, to demonstrate to others that they needed to get vaccinated. And this was a vaccine clinic that occurred in the hood, in a community, and we were actually vaccinating seniors. Anyone over the age of 70 was getting vaccinated, I believe, on this day. We know that hand washing works. Even though we don't have a lot of fomite transmission from this particular disease, it is still possible. So hand washing is still important. We know that our containment strategies work. The idea of testing, isolation, quarantine work. Now, when you have a huge outbreak that we have right now, we may not be able to do the contact tracing. And putting that on the shelf, particularly in some situations, may be the thing to do as we go forward with these very rapidly moving infections, where you really don't have enough time. By the time you know someone's infected, contact tracing isn't very good. But to the extent we can do it, we should do it. We know that social distancing worked. This is a map from 1918. In Philadelphia, they didn't social distance. They had high mortality and morbidity and a big spike in deaths. St. Louis, which had a much more moderate outbreak because they did social distancing. And we know that it worked because it worked early on in the outbreak to flatten the curve. We're not doing that now. And so we're seeing our hospitals overwhelmed. We know that flattening the curve works. But our societal interest in this has diminished. our tolerance for closing things has dramatically diminished. But also our understanding of what works. You know, we know that kids can go to school now. We know we can protect them in kids in school. We know how to do that. So kids should go to school because we know the overall risk that they have of being out of school. When you put all of the risks together, so their societal issues, their educational needs, their need for access to food, and overlay the infectious disease risk as part of that process. We know that therapeutic interventions got better over time. You know, we started by intubating everybody, putting everybody on a tube, everybody on a ventilator. Found out that was probably not a right way to do that because of what the pathophysiology of the disease was. We got better on pulmonary management. We've now developed some effective antiviral agents. We still don't have enough of them. That's the big problem. We're gonna have to scale up the manufacture of that. We know that this is a disease that creates a huge inflammatory response. And so steroids work. We know the antibodies work because antibody-rich plasma works, as well as these monoclonal antibodies. So we have the tools that we now need to treat you if you get infected. I would argue that I would prefer to not have to treat people. I spent my first 20 years as an emergency physician, and I can tell you it's always better to prevent a disease than to have to treat a disease. It's good to have the therapeutic options when you need to treat them, and we can do marvelous things, but you don't want to get this disease, so take the shot. Let me go here. So the question is, where do we go from here? We know that this is a picture of the Omicron variant, the Delta variant on the left, the Omicron on the right. The little red spots are the changes in the structure of the virus. And Omicron, we know, is much more infectious, but appears to be less pathogenic. But mutagenic potential is not linear. So viruses may not get worse over time. They do what they want to do over time. And so it is possible, even though everyone's worried about the virus that we're going to get from, some other part of the world that's less vaccinated. Let me argue that there are parts in our country that are under-vaccinated that are just as likely to have a severe mutation come from that part of the country. And if you don't think that can happen in our country, the Great Pandemic did not come from Spain. The Great Pandemic started in the United States. It evolved out of Middle America, most likely. And so these things can evolve. These viruses make millions of copies of themselves. And when they do so, sometimes they make mistakes. We know the three things that result in this is the ability of a virus to be transmittable, its virulence, and its ability to evade our immune response. We know that all viruses evolve over time. And as the virus circulates, the more they evolve. We know that there are some significant prevention strategies to slow this spread of Omicron. Number one, again, vaccination. Now we can give it to everybody over the age of 5, and we can give boosters at least over the age of 12. Increased use of masking, again, recognizing that N95s and KN95s, if you get the ones that are been shown to work, because there are some KN95 masks that are fraudulent and don't work. But get a good mask that's tightly fitted, or cloth masks in multiple layers will be effective. Improving the ventilation, particularly in our schools, do it as much as we can outdoors. I'm sitting in Maryland right now. Going outdoors is not an option. It's pretty cold and pretty snowy. But what we can, we should do that. And of course, much more testing and effective testing, and adhering to quarantine and isolation guidelines. It's going to be important. So what's the future of public health? Clearly, I mentioned public health leader needs to serve as the chief health strategist in community. That agency needs to be structured to deliver the 10 essential services. We need to have timely and actionable data systems. We need to harmonize the statutory authorities across jurisdictions, which means that we need to get the right public health authorities. We need to push back against legislators and elected leaders and the public that want to take away public health authorities that protect the public. We need to be very thoughtful about what those authorities need to be, and we need to strengthen them when appropriate. We don't need to have laws that we don't need to have, but we need to have all the authorities that we do need to have. And we need to be thoughtful about how we do that. We need to have adequate and sustainable funding. We need to have very vibrant cross-sector partnerships and an accountable, accredited public health system. I'm a strong supporter of the Public Health Accreditation Board and believe that every health department ought to be accredited. So what would such a system look like? So imagine if we had asthma. It's a common clinical condition. It occurs all the time. It's involved with disproportionately in communities of color. And if we understand how we can prevent this from happening when you have asthma outbreaks, that would be a good thing. So imagine we had an outbreak in a community on a particular day. And think, we just went through this infectious disease outbreak, but think of asthma from an infectious disease perspective, where you have these 4 hospitals with small numbers of cases that present in the hospital on a particular day. No particular hospital would pick this up as an outbreak, but the fact that you had 10 cases on a given day, severe enough to go to the hospital, most folks would think that would be an outbreak. Most people think of an outbreak as 3 or 4 people. So this would be an outbreak by any infectious disease definition. The public health department would get notified. An epidemiological investigation would be done. They would find that the kids went to the same school. They lived in different areas. They were all out of school on the same day. And they all didn't have the different insurance coverage. So it wasn't they were being denied care or any movement based on their insurance coverage. But nobody would have picked this up except the health department. And part of the fact that they went to the same school, the school was involved in recognizing they had these kids out on the same day for a similar chief complaint. So they do the epidemiological investigation. What do they discover? That all the kids rode on the same bus. And the bus basically, when inspected, had a broken tailpipe. Broken tailpipe, noxic fumes go into the bus, trigger an asthma attack. All the kids end up going to the ER on the same day. So who's the hero of the day? Well, public health would like to think we are, that's true. But the hero of the day is the bus mechanic, because they go and inspect all the buses and they find and fix not only the tailpipes, but some other things they found that are broken. And in doing that, through a collaborative approach between the school, the transportation system, and the health department, you now can reduce emergency department visits, you save money, you improve the health and wellness of the community. To the extent that this is a health disparity, you address the health disparity. You keep these kids in school because we know school is very, very important. And at the end of the day, you made the transportation system safer. So multidisciplinary collective efforts using data to address public health problems, to address societal problems, may not necessarily be viewed as public health, is very important as part of creating a system as we go forward in the future. There's no question that such an integrated system can treat any health threat, whether it's chronic diseases or climate change and severe weather, product contamination, terrorism, toxic exposure, and I would even argue firearm-related violence can be addressed through these comprehensive collaborative efforts. And I believe the central challenge for the nation is how to build this next generation public health system. I think it's important. The Wall Street Journal said it best. Wall Street Journal, as you know, is a fairly conservative publication, but they pointed out the fact that the public health system can tank the economy. And if anyone doesn't believe it, they've not been living in the same world that I've been living in for the last couple of years. We need to invest in public health because it can save lives and improve the health and well-being of our public. So the next generation public health system would radically transform and fully integrate both public health and the healthcare system. We have to have the comprehensive capacity to track and evaluate all pathogenic organisms, a robust system to forecast disease. We need strong and capable emergency preparedness leadership, both in government and outside of government. We should enable public trust in science and government. We got a trust problem right now. We we've got to work on, and operationalize health equity throughout the public health and healthcare enterprise as part of the process. I like to close with this quote, which I like, which says that until the story of the hunt is told by the lion, the tale of the hunt will always glorify the hunter. And I think public health is going to have to tell its own story, because right now we got so many other people telling our story, and they're not telling the story right. And they're not giving us the support that we need. So we need to be more vocal. We need to be more engaged. We need to yell from the rafters, but we need to be right. And we need to use science and education as our strongest tools to build the trust and well-being of our communities. With that, I'll thank you. And I will stop sharing my screens, and I'm happy to take any questions that you have.
Thank you so much, Dr. Benjamin, for your thoughtful remarks and comments. So much of what you shared resonated with me, given my day-to-day role at CDC and over 20 years at CDC in a variety of outbreak responses, but also chronic disease prevention, vaccination, our global work. And so one of the things that you mentioned was the need for public health to tell its own story. Science, education, and improving the trust of the public. What, if any, public policy solutions exist to help with us telling our own story, and or also helping to combat the disinformation that we are seeing and continue to see over the course of this pandemic?
Yeah, I think one of the things is public health is an entity that likes to educate the public, and we can be pretty good at it. So we need to do a better job of teaching and training our at all levels of our workforce now. It used to be you had to train the health officer. Now you got to train every program director, and even below, high risk communication. Risk communication is an important skill that we need to make sure everybody is competent at. We need to give people, through policy and funding, the capacity to address in the social media space. We need to train people better in using social media. Because right now, quite frankly, a lot of policy is being developed by tweet. And that means we're going to have to respond by tweet. And that's a challenge that we're going to have. We have processes to make sure that we're putting the right information out to the public, and it's not just spontaneous, but you've got to be fast. So fast communication is going to be very, very important as part of this process, because once a piece of misinformation is put into the social media ecosphere, your ability to respond to that can't take 2 days. You're going to have to be able to respond to that, very, very quickly, and with the right information, and not in a way that's threatening anyone or undermines anyone's credibility. That's not what we're trying to do. But we are trying to put the facts out there, and then let their credibility lie on the fact of the debate between who's right, and getting people to go to creditable places. The web is a wonderful place for information. In the old days, when we controlled the information, our word was king. But nowadays, you can go to the web and get all kinds of information. The problem is a lot of it is just wrong. It's just not credible stuff. And so I think we have a lot of work to do there.
Thank you. You also mentioned earlier on in your comments about our systems failures and how our systems failures with this Colbert response aren't new. Sort of dating back to anthrax and other situations that we've come across. What is it that is sort of preventing us from taking those lessons learned and applying them in advance of the next outbreak or in advance of the next public health emergency?
You know, we give you an example. When we put together our preparedness plan at the state of Maryland, this was back in it was before 9/11. We were working on updating our emergency preparedness activity, and we were working with the hospitals in Maryland, and we were encouraged them all to have a primary and secondary supply source. And by the way, they did that. And then we asked them to share with us what those sources were on a confidential manner. And what we, of course, rapidly discovered was they all had the same primary and secondary supply sources. So in essence, they had, you know, through no fault of their own, but they basically all had a single point of failure. If that one supplier couldn't, you know, provide for their needs, then nobody in the state would be able to get those supplies. So we made them aware of the fact that they needed to diversify their supply sources. Second thing, because hospitals have been, you know, and we've, you know, boards and everyone's been trying to tighten up our funding for supplies, equipment, we've gone to just-in-time supplies for everything. I can tell you that in the first week in February, right around Martin Luther King Day of 2020, I was at a meeting of some very high-level CEOs of major health systems in the country and the head of the American Hospital Association. And we were talking about the fact that there was a problem getting PPE, gowns and gloves, where there was trouble getting them. And we were talking about solutions to that problem. So we were having supply problems before 9/11 hit. I mean, before COVID-19 and SARS hit. So, and it was due to the fact that people have tightened up their supply lines. And so that's something that we have to also have to do is tighten up those, you know, loosen up those supply lines, make sure that we have companies in the United States that we control. As you know, we had a lot of nationalization of stuff that occurred early in the pandemic. You know, countries are supposed to share, but quite frankly, for a lot of reasons, they're going to make sure their population is taken care of first, and you can't fault them for doing that. So we have to make sure that we as a nation have our own access to this stuff. Let me add one more thing to this. When the hurricane hit Puerto Rico, the FDA rapidly went to Puerto Rico because most of our infusion bags come out of there. And so the ability to actually give people IV fluids, medications by intravenously was impaired because of that. In addition, a lot of our medications are produced on the island. There are warehouses on that island with store stuff. And so we've got to have redundancy in all of our systems if we're going to be successful. And that's got to be planned redundancy. And we're going to have to accept the financial costs for that redundancy as the cost of doing business.
Thank you. We have a question from our virtual audience. What can we do to coordinate and synergize healthcare dollars and data in public health and Bureau of Primary Healthcare and federally qualified healthcare centers?
Yeah, we clearly need to build a data system that exchanges data. We have to respect patient confidentiality and privacy for sure, but we're going to have to build that system. Look, right now, no matter where you are in the world, even if you're on a cruise ship, you can get money from an ATM. But there are many parts of our country where they can't move the electrocardiogram that you have across the street when you need it, 24 hours a day, 7 days a week. And so we have to build a system that is interoperable, that is fast, that requires people to fill the boxes out. You know, part of the problem on the early part of the pandemic, we were all yelling at CDC, tell us the disparities data, tell us the disparities data. And the fact of the matter was, CDC often didn't have the data. The data was coming in slow. Forms were being sent in by fax machine to the state and local health departments. You know, 2 people removed from who collected the data. And if they hadn't filled out the box around ethnicity, you had to go back and validate. So, and then of course, making sure that you have enough data that you can make informed epidemiological, and statistical decisions based on the data you have means you have to have the right data and be able to validate the data. So until we have a system that is fast, of high quality, and stop investing in little pieces of a system and say we're going to build this immunization registry over the next 10 years. No, we need to decide we're going to build a system with the technology that we have today, with the speed and efficiency of the private sector who wants to make some money, and recognize that doing that, we can save lives.
Thank you. We've been talking about that for quite some time. I hope we have reflected and recognized the need for and really act on it this time. What are your thoughts about ways in which we can prevent and respond to the politicization of state and level public health policies?
I think you heard from one of your legislators early on about the importance of going to see them before you need them and building those relationships early. So you need to build those relationships. You need to build those relationships across the political aisle so that you build trust. And then you need, when somebody decides to put in a bill, or you get a hint that someone's going to put in a bill that you think undermines the authority that you have, you need to go see them and sit down with them. Don't embarrass them. Don't publicly, argue, yell, and scream at them. Go see them, explain, at least initially, why you think this is not going to work, and explain what the risks are. And then hopefully you'll have a good debate, assuming the bill comes up for a hearing, and make coherent arguments. Also, build the advocacy group that you need to have so that they understand the public does not want them to change those laws. The public does not want them to put in place a rule that says we cannot require masks, that we cannot order people to be vaccinated, because the time will come when they will find that that law is prohibitive. And it's in case in one health department, they had laws that were passed and they just threw their hands up and said, okay, you call us when you want us to do something, because you just stopped us from doing anything meaningful. And we don't want that to happen. We want to be able to protect the public. Do not put us in a situation where we can write tickets, but we can't arrest. There's no way in the world you would let your police department identify that a crime occurred, write it down on a piece of paper, and not be able to act on it. That's exactly what they're doing to public health today. And people will die because of it. And I'm not overstating that case. People will die because of that. And they will wish they hadn't done it. And by the way, reversing those things legislatively is always more tough than putting it in place in the first place.
That's a great analogy. I'm gonna have to use that going forward. We have another question. How are we monitoring COVID-19 home tests with public health departments, and how are we reporting the findings?
So you're not required to report your home tests, but we're encouraging people to report their home tests. And I argue two people. Number one, you should make sure that your personal practitioner, your health physician, your health provider know if you're positive. Because if you're positive, particularly early on, they may be able to offer you, once we get enough of them, therapeutics to help you if you get sick. And particularly if you're not vaccinated, you need to make sure that they know that you're positive. Secondly, obviously, calling you and notifying your state and local health department. To the extent that they may not be doing contact tracing because of the volume of cases, sometimes that information is helpful for them to connect the dots as part of their disease tracking and surveillance efforts. So I think both of those, realizing that your physician needs to know for your personal health, your health department needs to know for your community health. Obviously, also if you're positive, you should let people know that your coworkers, if you were recently around anybody, your family members know if you were anyone you might have exposed. Obviously, you can't, say I was in the grocery store yesterday and notify those folks. But if you have family members or coworkers, if you haven't been in their office, you should notify them directly. Don't wait for them to be notified by the authorities, because particularly Omicron has such a short incubation period. It's very difficult. By the time they've been notified, they're outside their 5-day period. If they've gotten sick, they've gotten sick. Obviously, but the way to avoid all of this, in terms of it being relevant, is to be vaccinated. That makes it much less likely you're going to get sick yourself, and much less likely you're going to spread it to somebody else.
Thank you. One additional question. If we've heard earlier on part of the session, some of the stats related to Georgia. So if you were advising a state like Georgia, where would you recommend we direct public health funding and or prioritize public health funding for the state of Georgia, both at the state level and at the local level?
Well, I want to be respectful of your legislators, and I know that they work very hard to make sure that they're providing their support. You could see the care in which their answers and thoughtfulness for the panel you had earlier. And they're right. Georgia can't produce money, but there are many things that they do have control over. And so, for example, Georgia should expand Medicaid coverage to everyone. I know there are some views among some people that, not in the rest of the world, that Medicaid is a failed program. It is not a failed program. It is a highly effective program. And in fact, the data shows that people who, the states that have expanded Medicaid overall do better in the health outcomes of their population than states that have not expanded Medicaid for the Medicaid population. That's first thing. Secondly, the rates in which they pay Medicaid providers is within their control. That's a state decision. The feds have to sign off on it, but and I know that Georgia has done some efforts to prioritize that funding, and they may need to do, as you heard, more funding to get OBGYNs. We experienced that in Maryland too. And by the way, what we did was we increased funding for those specialties that we needed to have, and we increased funding for primary care. And we did it over time. We basically said, okay, we want to improve funding for providers. And so we laid out a multi-year strategy to increase funding. And every year we improved that funding as a matter of decision-making as a top priority. The reason for doing that is that if people see they might get a raise next year, they're much more likely to participate in the program. They're much less likely to leave the program. So doing that is one way to cement your workforce in the program, and then to try to grow it over time. But it has to be substantial funding. And Medicaid is a best buy. It is the best. It is cheaper for you to get someone into primary care and get them treated than to get them treated in the emergency department. Every day, it's a best buy. So I'm an advocate for that. Second thing is looking at policies, the social determinants of health. 80% of what makes you healthy occurs outside the doctor's office. So addressing things like making sure the sidewalks get fixed using your infrastructure dollars, making sure that the playgrounds get fixed using your infrastructure dollars, supporting both using the Biden dollars that are out there, the infrastructure dollars, to support things that support health as well as support infrastructure is a marvelous way to do that. I'm going to say support the Build Back Better bill and get your members of Congress to support the Build Back Better bill. It's going to be very important because those dollars will dramatically improve the societal needs and well-being of your population. Looking at laws that should be taken off the books, that have been there for years, that may not be enforced right now, but serve as a barrier to people getting care if they choose to be enforced sometime in the future. Rules around segregation. And by the way, I'm going to speak up for voting because voting is a public health intervention. And we ought to make sure that everybody has the right to vote. No question about that.
Thank you.
And that may sound political. It ain't political. It's the basis of our decision-making in this country.
Absolutely.
And if you get the right people voting and people who support public health, then we will be able to go in and much more likely be receptive for improving the health and well-being of the population.
Well, the right to vote is not a partisan issue. It shouldn't matter. Everyone has that right. I certainly agree. Can you speak to how primary care is part of our public health systems? We don't, I don't think people realize the importance of primary care and how we can better support primary care. We've been talking about it for quite some time. I think we heard one of our legislative partners earlier talking about the importance of primary care and how individuals coming out of medical school choose specialties because sort of the higher salaries as opposed to primary care and being stuck with medical student loans and that sort of thing. And so primary care is not really an option for some folks. How do we better support primary care and integrate it within our public health system?
Well, there's no question that primary care, look, public health, the United States is the only country in the world that has a public health system and a medical care system. Everybody else has a public health system of which medical care is a part of their system. Having said that, public health is clearly a spectrum. Primary care should be viewed as the essential system to do prevention, early intervention, and well-being. We need to strongly support it. We need to pay for it. We need to pay things based on value. And prevention has value. Primary care has value. We need to make sure that pediatricians and OBGYNs and family physicians and internists get paid a meaningful wage for the work that they do and the time that they put in to what they do. We need to make sure that telemedicine visits don't go away because that is an effective way to provide care for folks, particularly in rural communities. One of the reasons for expanding coverage in rural communities and expanding Medicaid coverage is to support the economics and of your physicians in your rural communities as well as your rural hospitals. And again, making sure that we have a comprehensive delivery system in all aspects of the community, putting in place decisions about how far you want any person in Georgia to be from access to care, and actually put that in your state health plan so that you use your dollars and your resources to incentivize any way that you can, providers, institutions to go in those communities to provide care. You're right, scholarships to help them pay their medical debt is important. Making sure you have enough slots in both your medical school, your nursing school is important. And one of your legislators mentioned the goal of making sure that everyone can practice at the top of their license. Physicians should not be threatened because physicians, assistants, and nurse anesthetists exist. There's enough work for everybody. Didn't COVID teach us that? We should not worry about what they do. They can provide high quality care. They have to be well trained, they have to be properly supervised, and they have to be properly credentialed. If we do that, excuse me, if we do that, we can make sure we have access to care for everybody.
Thank you. And I think this will be our last question. If we're talking about, you mentioned the Wall Street Journal article and reference the importance of investing in public health as a nation. How do we make the investment case for public health? Particularly when we're talking about prevention and quantifying prevention when you're preventing something that you can't see.
That is always a challenge in communications, but the construction community has figured out how to do that pretty effectively. All those signs, go around Atlanta, all those places where those construction going on, they have a sign that says X number of days, no injuries. So why don't we tell people that? Today we had no injuries today. We didn't have anybody die from X today. We do that, we do the opposite. we talk about how many people, had bad healthcare outcomes. What we ought to do is we ought to make a big deal every time something bad happens to somebody. Every time somebody has a heart attack, we ought to talk about that was a preventable event and what we could have done about it. Every time somebody slips and falls on the ice, we ought to talk about that being a preventable event with somebody and what we could have done about it. Someone gets commits suicide with a firearm, or a firearm goes off inadvertently and someone is killed or injured. We don't talk about how that could have been prevented every single time. They ought to be so sick of us telling us how to prevent stuff, so that we're no longer silent, that we're in their face each and every day, so that these silent episodes of prevention don't go unnoticed. Every time somebody gets a glass of water, they turn on the faucet, they drink a glass of water, and they successfully ingest that water without getting sick from from infectious disease. That's a win. And so we need to make sure that people understand that public health is about clean water. It's about having air that's safe to breathe and food that's safe to eat, a community that's safe from violence. And we need to make sure that every day they get up, they recognize that over the last 24 hours, they got through that day successfully, not by luck, not by chance, but because public health did something in a planned, concerned, productive way to ensure that you didn't, get sick or die or seriously injured. It didn't happen by accident.
Thank you so much. And I think that goes to your point earlier about some of the modeling and analytics and predictive analytics that we can bring into where public health has sort of been shied away from using some of that modeling, particularly in the public health sector, to help quantify what the role and value, as you stated, of public health is in our day-to-day lives.
Well, we're at Best Buy. And yeah, we ought to get our economics folks to show the savings. We ought to point out that vaccines not only save lives but are one of the most effective tools we have to save dollars. We ought to show that prenatal care is effective, and we can show them where the savings can be and where they won't have to spend it. And I'm okay with reducing the cost for the critical care side of the house, and on a planned way, moving it to the prevention side of the house. We can do that in a planned way. They're going to spend the emergency money anyway. So let's make sure they put the money on the prevention public health side of the house.
Well, thank you. We have come to the end of your session, Dr. Benjamin. Thank you so much for joining us. Thank you for your presentation and sharing your thoughts and insights with us on how we can not only improve our public health systems, but the role that policy legislation has, how we can think about discussing more about the value of public health and prevention, and how we should move forward with helping to curb some of the misinformation and do a better job of telling our story. So thank you for joining us this morning. I'm going to turn it over to my colleague, Dewana.
Thank you, everybody, for your time. I wanted to say, wow, we did receive a wealth of information today, and my name is Dewana Burke, and I'm a board member for Georgians for a Healthy Future, and am grateful for your time and participation today. I, like you, have been impacted by this pandemic in a way that makes me want to be the change that I want to see. My hope is that the insights shared by our bipartisan panel, as well as the keynote from Dr. Benjamin, helps you to understand the opportunities to further impact our communities in a meaningful way. As we bring this event to a close, I would like to first thank our champion sponsors, Hemophilia of Georgia and PHRMA, as our champion sponsors, as well as all of our sponsors of this year's Healthcare Unscrambled. So thank you very much for your generous donations. Additionally, If you like the content that you saw here, as well as the insights that you get from us on a pretty frequent basis, I would like to encourage you to support the work that we're doing here at Georgians for a Healthy Future by consider making a donation, either one time or on a monthly basis, by visiting our website at healthyfuturegeorgia.org/donate. And you can also see that link there in the chat. You can also dive deeper in our website on our policy priorities, which include COVID, mental health, substance abuse, Medicaid expansion, public health, and other urgent issues that we are really speaking about and encouraging you as well as our followers to lean in with our legislators on. Again, thank you to our presenters for your insights, and to you, our audience, for leaning in, asking questions, sharing on social media, and being the change that you want to see in your community. And thank you so much for joining us here at this year's Healthcare Unscrambled. Thank you all so much for your time. Bye-bye.